Good afternoon, everyone. So we now come to the second case of today's CCR session from the Department of Ophthalmology, Dr. Rajendra Prasad Center for Ophthalmic Sciences. We have an interesting case to present. Plus, the surgical treatment of this patient was also slightly unusual. So we hope the case will help people understand a different aspect of ophthalmic care. And
History of present illness. She was apparently asymptomatic 10 days back when she noticed sudden onset pain, redness, discharge, and diminution of vision of left eye. After 3 days, similar complaints were noticed in the right eye too. And she had also noticed painful ulcers over the finger, foot, scalp. So here on this clinical picture, we can see there is an ulcerated lesion present over the middle finger of the right hand. Surrounding skin is peeled off and the ulcer margin is clear. Similarly, on the dorsum of right foot, we can see the clear margins of the ulcer with central necrotic area. Coming to ocular examination, right eye, uncorrected visual acuity 612, intraocular pressure was 18 millimeters of mercury. On eyelids, there was edema was present with matting of eyelashes, and conjunctiva diffuse congestion with boggy conjunctiva along with mucopurulent discharge was present. Examination of left eye, her uncorrected visual acuity was hand movements close to face with projection of rays accurately in all the 4 quadrants. Intraocular pressure we could not record, so digitally it was coming low. And eyelids diffuse edema was there with mechanical ptosis and matting of eyelashes were present. Conjunctiva was boggy with diffuse congestion and mucopurulent discharge was present. This is the clinical picture. Here you can see when the patient has opened her eyes, we could hardly see the cornea. In right eye, only the inferior part of the cornea is seen, and the inferior bulbar conjunctiva is quite boggy, along with matting of eyelashes is there. Similarly, in left eye also we could see that there is discharge which is present over the eyelashes, and along with crusting and matting of eyelashes is there. After we removed the discharge, we could examine the cornea of right eye, and it was appearing normal in shape and size. It was clear, surface was regular, and sensations were also normal. Sclera, there were no evidence of any nodules or ectasia. Anterior chamber was Van Herrick's grade 3. There was no evidence of uveitis. Iris was also normal. Left eye we could not examine as it was difficult to remove the discharge, and there was nasal symblophron present, so it was quite painful for the patient also, so we could not examine the rest of the structure. So we planned for examination. This is the clinical picture. Here we can see after removing the discharge, we could see the cornea, it's appearing clear. But in left eye, we could see here there is a nasal symblophron is present. Symblophron is basically, it's an addition between palpebral and bulbar conjunctiva. And along with that, crusting of eyelashes is also seen. We could hardly see the cornea here. Right eye examination, pupil was circular, reacted to light, there was no synechia, lens was appearing clear, and dilated fundus examination was also within normal limit in right eye. Left eye we could not assess. So we submitted the child for examination under general anesthesia, and after removing the discharge, this was the clinical picture we could see. We saw that there was a scleral necrosis with exposed uveal tissue from 8 to 10 o'clock, and there were 360-degree peripheral ulcerated lesion with corneal thinning was present along with avascular zone. Similarly, we also sent the swab for microbiological examination for staining and culture sensitivity. And we started the patient on empirical treatment. Along with that, moxifloxacin eye drops 0.2% 2 hourly was started in right eye. Along with that, hometropin 2% QID for left eye. So the patient was planned for repeat left eye corneoscleral patch graft for the 3rd time. And here we could see the visual acuity was 3/60 on post-op day 1. Graft was in situ, sutures were intact, it was well buried, there was no leak. Anterior chamber was well formed and lens was appearing clear. This is the anterior segment OCT of the left eye. Here we can see there is iris adhesion with the cornea on the nasal aspect. Patient was on regular follow-up, and after 3 months, he had come to our clinic. Ocular examination was done, and right eye her uncorrected visual acuity was 6/6, intraocular pressure was 14. Cornea was clear, anterior segment was within normal limit, and fundus there was no evidence of any vasculitis. Left eye her vision has improved to 636 with intraocular pressure maintained at 16 millimeters of mercury. In cornea was clear with a peripheral skirt of nebulomacular corneal opacity, sutures were off, and she is pending for contact lens trial. Her anterior chamber was formed, pupil was round reactive, and lens was clear. Fundus evaluation, there was no evidence of any retinal vasculitis. This is the clinical picture. You can see here the cornea is looking clear with the peripheral opacity is there and sutures are off. On follow-up, she was her topical steroids and antibiotics were tapered and stopped gradually. Dapsone was stopped after 3 weeks. Prednisolone was gradually tapered and stopped after 3 months. Tablet azathioprine was going on. She was started on 25 mg and it was gradually increased to 50 mg for 2 weeks, followed by 100 mg for 2 weeks. And after monitoring of blood investigations, now the patient is on 150 mg of azathioprine. This is the clinical picture. Here we can see she's now comfortable opening her eyes nicely. But the only thing is that she has gained a lot of weight because of these medications. Coming to discussion part, PUK with Behçet's disease. Features which are present in our patient is that oral aphthous ulcers and genital ulcers were present, skin lesions were there, there was involvement of peripheral cornea in both eyes and necrotizing scleritis. But the features which are classically seen in Behçet's were absent. So there was absence of iridocyclitis. There was no evidence of any uveitis on patient and systemic workup was also negative. But then why Behçet's? Before that, we have to see various criteria for Behçet's. There are 3 criteria. First is Behçet's Research Committee of Japan, which was given in 1972, followed by the International Study Group of Behçet's Disease, which was given in 1990, and International Criteria for Behçet's Disease, which is the latest one given in 2006. So, Hulusi Behçet, he was a Turkish dermatologist who has discovered this Behçet's disease. He, during his practice, he used to see these kind of cases which were having recurrent oral and genital ulcers along with inflammation of eyes. So all these various unique cases he has compiled and he has published in Archives of Dermatology and Venereology in 1937, and he has given a classic triad of Behçet's disease which includes oral ulcers, genital ulcers and inflammation of eye. So in this article we can see that Behçet's disease is a chronic relapsing vasculitis that can affect most organ system. And coming to ocular involvement, we could see it affects both anterior and posterior segment of the eye, and the main manifestations includes iridocyclitis, which is hypopyon iridocyclitis, mild to moderate vitritis, retinal vasculitis, vascular occlusion and optic disc hyperemia and macular edema. It also says that there is no pathognomonic laboratory test in Behçet's disease. Coming to this criteria, Behçet's Research Committee of Japan, it has 4 major and 5 minor criteria. In our patients, skin lesion and inflammation of eye was there. And types of Behçet's they have given complete, incomplete, suspect and possible. Incomplete, all 4 criteria should be present. Incomplete, 3 major or ocular involvement with 1 other major criteria should be there. In suspect, 2 major, no eye involvement, and possible 1 major should be there. Coming to this international study group for Behçet's disease, mandated criteria is there that there should be recurrent oral aphthous at least 3 times per year, plus 2 of the following criteria should be there, which is recurrent genital ulcers, skin involvement, ocular inflammation and positive pathology test. In skin involvement, it refers to pseudofolliculitis and erythema nodosum, and ocular inflammation refers to anterior uveitis, posterior uveitis and retinal vasculitis. This is the latest classification, international criteria for Behçet's disease, which was given in 2006. Here various criteria are given. Along with that, scores are being given. So genital aphthous ulcer has been given 2 scores, eye lesions 2 scores, oral aphthous ulcers 1 score, skin lesion 1, vascular manifestation. In terms of thrombosis and aneurysms, 1 score has been given, and positive pathology test has been given 1 score. So it tells that 3 or more points gives diagnosis or classifies as Behçet's disease. So in our patient, it was 6. So our final diagnosis was both eye peripheral ulcerative keratitis with Behçet's disease. Now I'll just go through some articles. So in this article, it has told that the epidemiology of Behçet's disease is highest seen along the Silk Route, in which Turkey the incidence was maximum, followed by least it was seen in UK. And in 95% of patients, oral aphthous ulcer was seen. Around 60 to 90% patients, genital aphthous ulcer was seen, and ocular manifestations such as uveitis and retinal vasculitis was seen in 45 to 90% of cases. And coming to pathology test, around 8.6% of patients were only positive from India. So highest prevalence was seen in Turkey. And coming to age of onset, it's mostly seen in 3rd decade of life, and most frequent first manifestation is oral aphthous. And males are more involved than females. Coming to HLA profile, HLA-B5 is present only in 53.3% of patients and B51 in 47.9% of patients, followed by B27 in 8.6% of patients. Pathology test was positive in 52.5% patients in Iran. This is the largest study which is done in Turkish patients, giving the patient characteristic in Behçet's disease. So they have studied that female is to male ratio is around 1.04 and mean age of onset is 27 years. And most common presentation were oral abscess lesion, genital ulcers and skin lesions. Eye involvement was not affected by age of onset. And they also concluded that pathogenesis of Behçet's disease is multifactorial, while genetic background and environmental factors play a major role. Coming to pediatric onset Behçet's disease, only very few literature search is there. So from these two articles, I conclude that 34 children with uveitis and Behçet's disease were studied. Again, they had showed that pan-uveitis was a leading type with 52.9% prevalence, and optic atrophy occurred in 29.4% of the patients, and it was the most common posterior segment complication. Anterior uveitis was the most common ocular finding in 13 patients younger than 10 years of age, whereas pan-uveitis was most common for those older than 10 years. So the authors of the latter study also highlighted that the frequent family history in patients younger than 10 years was present. Coming to some studies from India, it was done by Department of Dermatology. They studied around 29 patients, and they said that the disease had a female preponderance and mean age was 27.4 years, and ocular involvement was around 31%, and pathology test was found to be positive in around 31% of cases. And disease occurs in a much milder form in India and is primarily mucocutaneous and arthritic in origin. Coming to ocular manifestations of Behçet's disease in Indian patients, they have studied around 19 patients, and they found that the common manifestation was conjunctival ulcer followed by iridocyclitis, and the severity of ocular disease is relatively low in Indian patients. This was a study done in Oman. They reported that a 35-year-old Behçet suspect on azathioprine presented with conjunctival ulcer, which was subsequently treated by immunosuppressants. This was also a case report on conjunctival ulcers. They also have studied that they have taken biopsy from these ulcers, and they have found that it was positive for CD68 positive histiocytes. This is a rare presentation of Behçet's disease, which is reported by Shankar Netralia. This was a 45-year-old female who presented with nodular scleritis, and she also gives history of recurrent oral and genital ulcers. And she was treated with colchicine and dapsone and deflacort, but her HLA profile was negative, and other antibodies were also negative. This is a rare case report of peripheral ulcerative keratitis associated with Behçet's disease. In this case, there was a 34-year-old female who was HLA-B51 positive and has been treated with systemic corticosteroids and cyclosporine. So he presented with deep ulcerative lesion with perilesional haziness in the peripheral cornea of the right eye. This is the clinical picture here we can see. This is a case report where corneal perforation was present in a case of Behçet's disease. This was an 80-year-old Chinese man who had a history of recurrent GI bleed with diverticulitis. And he also presented with recurrent ulcers of mouth, genital, leg, foot, palm, and forearm. And he presented with mild iritis in his right eye. He was treated with oral prednisolone. And for left eye, topical steroids were given along with BCL glue was done. This is a 2018 update of the EULAR recommendation. EULAR stands for European League Against Rheumatism, which has given around 9 recommendations for the treatment of Behçet's, and it has been concluded by experts from different specialties such as internal medicine, rheumatology, ophthalmology, dermatology, neurology, gastroenterology, oral health and medicine, vascular surgery, along with methodologists. So I won't be discussing all the 9 recommendations. I'll be just discussing 3 recommendations. Anti-DNF antibodies. And in isolated anterior uveitis cases, systemic immunosuppressive could be considered. Those with poor prognostic factors such as young age, male sex, and early disease onset.
Puja, that was quite interesting case. I mean, usually in this case is a very unique and a challenging case. Unique in the sense that this presentation, the age of presentation is unique itself, because when you see various literatures, it was around you see around 2 to 3 decades of the decade of the age. So initially it's around 13 years. Another issue is unique of this case is when you see the various case report here, the ocular involvement. When you see the ocular involvement, there's around 50 to 90% of batches will have got this anterior uveitis or posterior uveitis or retinal vasculitis. But in our case, we have not seen any of these features. In fact, we have seen a peripheral ulcerative keratitis and also a conjunctival ulcer and a necrotizing scleritis. So this shows that it itself is very unique, and also the challenging is like you have to undergo the 3-time surgery here, corneal transplantation. And the corneal transplantation here, it was not a simple, straightforward transplantation. Here you have to go a very customized corneal grafting have to be done along with the corneal and scleral patch graft also. So it was very complicated case. However, we'd like to thank our colleagues from rheumatology and from dermatology who have helped us in the diagnosis and given us proper complete management of this particular case, and having with this management of using steroid and then immunosuppression, this girl has really able to review the visions. And the one learning point from this particular case is when you see a case of peripheral ulcerative keratitis, though batchet is rare, but always we have to have a look into all the systemic evaluation to rule out batches. At the outset, I would like quickly invite Dr. Ranjan Gupta, consultant from rheumatology, to try a few points on further discussion of this case. Dr. Ranjan, please.
Thank you, Dr. Lomi. So this case was unique in the sense that it is a pediatric case. She is juvenile and she comes with an explosive onset of multi-system involvement, in the sense she has got eye involvement as well as skin ulcers, which are so clean, deep and well-defined margins. So with all these presentations, the first thing that one should come up with, the first diagnosis one should come up with some autoimmune disorder in the background. And she had this presentation of genital ulcers and this eye involvement. The first thing that came to my mind was patient, and that is how she has done beautiful, and I must congratulate the department for doing so many surgeries. I didn't know that she had undergone so much surgical management as well. So the learning point here is its explosive onset in any patient, be it a pediatric or adult age group, and has got multiple organs involved without any history of infection. Things should come to your mind is possible or not in etiology. Thank you.